Mm. Hello, namaste. I'd like to welcome all of you to the Karnataka Nursing Officers Academy, KNO Academy. First of all, I'd like to thank Dhananjay sir for giving me an opportunity to explore myself in the field of teaching. As being working in nursing officer, I've been deliberately waiting for the platform to explore me. So myself, Nagraj BK, I'm from Kalburgi. Studied in ASC Nursing College, Kalburgi, Karnataka. So now presently I'm doing the job at the Jipmar Puducherry Hospital. Since 3 years, it been working in a critical care setup. So the topics I've been delivering to you to coming days and all the upcoming series. So I'm going to deal with the critical care aspect topics only. So mainly I'm focusing on the consecutive sections. I'll be focusing on the only long stem questions and concepts and how you're going to approach the topic by applying your knowledge where you learned, where you studied, where you experienced. All you're going to put down here and you're going to solve the questions. Okay, you're going to solve the question and going to I'm going to reduce your stress by making the concept clear. So first of all, in this section, we're going to deal with the Airway series only. So some 5 videos I'll be making on Airway, and further on critical care aspects, ventilators, ICU, drains, tubes, oxygen therapy, and all. We're going to deal with the upcoming sections. So going to first question of uh, uh, of Airway series, we're having an we're having an We're having a 72-year-old male admitted in a PMRC ward with a pelvic fracture and elbow dislocation. Means the patient is having long bone fracture and is a case of old age case. The patient is old age. So what your main focus is patient is old age means immunologically weaker and is having a fracture, pelvic fracture, long bone fracture is there. And at morning, patient looks fine. Okay, morning patient look fine, but he's receiving some oxygen source, oxygen therapy, O2 at the 6 liters per minute. So till that morning, patient was okay, but he was receiving some kind of O2 he needed, but he was all right at the morning. When if you going to observe the patient in the evening, the patient became suddenly agitated. Okay, suddenly agitated, restless, and started to exhibit a respiratory distress sign. Okay, respiratory distress signs. So this word itself is an highlight. It's a hot topic of examiners. So almost if you're going to see the exams, means so much repeated exams are there. The repeated exams you'll be seeing the topic. You will be seeing the question with the respiratory distress sign. So it varies from children to adults. If you're going to see commonly means the signs of respiratory distress are first, first nasal flaring will be there. Nasal flaring will be there, and the patient start to use accessory of respiration. So that are your sternocleidomastoid muscle and abdomen muscles and your neck muscles. So this all are accessory muscles patient is going to use. And next is patient will be having ICS intercostal sternal retractions will be there. So you're going to see the dip in between your ribs. You're going to see the retraction depth will be there. Depth will be there. Like when the patient start to inspire, there will be a indrawing of the chest muscle. So that will be a intercostal attractions. And next patient will be having up and down means seesaw respiration means thoracic and abdomen movement. Okay, if chest cavity will go in and abdominal cavity will come out. That is what we call a seesaw respiration, paradoxical respiration. It's seen in case of paradoxical refracture, in case of refractures, multiple refractures. So these all are your respiratory distress sign, and there will be a hunger. There will be a more O2 need. There will be a need. There will be hunger of respiration. There will be hunger of air. Patient will struggle. Will struggle for breathing. So the all are your respiratory distress sign. So that time only the treating physician has taken a ABG. So ABG has taken and he told he crossed the ABG and the consecutive ABG value shows 7.12 pH and PCO2 of 58 mmHg and PO2 of 45 mmHg. So if you go to ABG, it's ABG itself is an on topic. It will take at least some 30 to 40 minutes lectures on ABG because it is like a critical investigation done in critical time. Before you're going to like do anything for a patient, you're going to say change the ventilator setting. You're going to prone the patient. You're going to change the ventilator setting. You're going to plan the patient for future ECMO and shifting to CT, MRI. You'll do on ABG. So it's like a point of care investigation. You will get the all parameters: sodium, potassium, PCO2, PO2, pH. All these vital parameters you can able to get it in a single prick. So in this as the topic came in between the question, so I'm going to like a little bit. I'm going to give a light on ABG, ABG, airway. Sorry, arterial blood gas analysis, ABG. In that mainly, okay, we will see here. What we'll see here only we'll see pH. Normal pH is 7.34 to 7.43, and normal PCO2 will be 35 to 45 mm of mercury, and normal PO2 partial pressure of O2 will be 80 to 100 mm of Hg. Okay, how this is going to depend? PO2, how what we can expected PO2 level? Expected PO2 level will be 5 times to that FiO2 fraction of inspired O2. Normally, if the patient is on room air, think patient is on room air, like a normal atmosphere content 21 percentage of O2. Percentage of oxygen concentration. So if you multiply 5 and 20, or approximately you'll get 100 percentage. So normal PO2 on room air will be 80 to 100 percentage. So and then bicarb levels. Normal it will be a 20 to 28 milli equivalents per liter. So this all your normal like you're going to see, you're going to watch in ABG. This like basic this investigation, basic this parameter you should be knowing thoroughly. So coming to the questions, what is dearranged here? pH is dearranged. pH is 7.12. So pH is 7.12. Our normal pH is 7.34 to 7.43. So pH is coming down. Rome, all of you like I think are about Rome. Respiratory opposite, metabolic equal means pH is going down and pH is going down and PCO2 is getting raised. So you can see PCO2 is 58 mmHg. So what will be it will be what you are going to diagnose this patient as? Patient is having respiratory or metabolic acidosis. As okay, patient will be having a respiratory acidosis. We diagnose the patient as respiratory acidosis. So continuing to the question. What all we got to know? Patient is having respiratory signs. Patient is agitated. Patient is restless. what are the first sign of hypoxia? In case of conscious patient, will be having a patient will be restless, will be agitated, will be getting out of the bed, will be fighting like anything. Means that O2 hunger will be there. So these are like signs of PO2 is getting calmed down and SPO2 is coming down, come down. So patient purely in type 1 respiratory failure. When there is an increase in PSCO2, there will be a CO2, carbon dioxide narcosis. Means patient will be over sleepy, over drowsy. That will be there. And if you see the questions, a patient is having disease of 8. Main like component of the disease will be EVM. Eye response, verbal response, and motor response. E4, V5, M6. Totally 15 highest score. And lowest score will be a 3. So patient is having 8 of the 8 GCS. So there will be something abnormality which is defined to you. So finally, ultimately, the examiner is asking you what is the next appropriate action taken. So as being a nursing officer, like if you're working in a ICU setup and all, this scenario will get up. So what will be your appropriate action? What you will anticipate? What you will be prepared for the patient in ICU? So in ICU, you'll be having all resources. You'll be having ventilators. You'll be having a bag and mask. You'll be having NIV. You'll be having suction machine. You'll be having O2, all O2s. Everything will be there. So the options are: first option is your bag and mask ventilation, bag and BMV, bag and mask ventilation, and suction and clearance. Sorry for the distraction. I need some space for clarifying your whole thing. So here is a space ready. Okay. So here are your options. First option is BVM, bag and mask ventilation. Okay, bag and mask ventilation, and next is your suction and clearance. Next, endotracheal intubation. Last, deep for non-invasive ventilation. So I'm going to tell a situation where there is. I'm going to I'm going to deal with all each and every options. Like if you go through first choice, bag and mask ventilation. You're going to connect the ambu bag. You're going to connect the ambu bag to the patient. Ambu bag will be there. You're going to connect to ambu bag to the patient, and you're going to try to ventilate the patient. Is that option is right? I think we are missing something. Okay, what is we are missing? See the scenario. Patient is in like restless and he is agitated. Does he going to cooperate to you if you're keeping ambu and keep on pushing the air inside his mouth? No. And can you wait for him to like for sometimes and you'll be waiting for sometimes and you think that with ambu you'll recover? See, already ABG parameters are deranged. He's going for a severe acidosis, severe respiratory acidosis, and patient sensorium is dropping. GCS 8 is indicative of altered mental status. Altered mental status. Or okay. So this is not a proper option. You're going to keep ambu and ventilate the patient means patient will further worsen. You're going to lose the patient. Okay. And next, what you're going to do? You will take a suction. You will take a yonker. You will take a suction catheter, and you'll put a suction inside the mouth and nasal cavity, and you're going to clear the upper airway, and you are going to leave the patient like this. No, only if you were like doing suction, the upper airway clear. What about lower airway? What about this distress signs and all? What about the ABG parameters already rearranged? You're not going to give the O2 means your PO2 is already now 45 mmHg. So it will be further like taken down, and it will be patient will be having hypoxia, hypoxic injury will be there, brain injury, encephalopathy will be there. You will get into the permanent disability in the patient. So suction is not an ultimate goal of treatment. So coming to third option, are you going to intubate the patient? Are you going to think that anticipate that the patient is going to intubate? I'm going to get ready with the salt. Yes, of course. Patient airway is threatened. So coming to the concept, there is a concept behind the endotracheal intubation. Uh, so if you feel okay, what are the indications of tracheal intubation? Tracheal intubation. What are the indication? If there is threatened airway, written development patient will be having like trauma to the chest, lungs, trauma to the neck. If you're having like zone 1, zone 3 fracture, injury to the neck is there. And if you're having mandible fracture, nasal fracture, like multiple facial fracture, and if you're having like a traumatic brain injury to the head and all. So that all like anticipated respiratory failure, anticipated airway injuries there means you can able to like intubate the patient. You're going to safeguard, you're going to stabilize the airway by putting the endotracheal tube into the trachea. And next, if a patient is comatose, so he's not going to maintain airway, then you're going to intubate the patient. You're going to take the patient on ventilator support, and you're going to put the patient on chronic ventilator support until the coma or it will resolve. And next, if you're going to see means there is an impending signs of respiratory failure is there means you're going to intubate the patient. What are the impending signs? Impending signs are all this I told. No, there is signs. If there is an distress signs are there. If PO2 is coming down, and if PCO2 is rising up, it's all like impending respiratory. Patient is restless. Patient is having hypoxic signs are there means. This you're going to intubate the patient. You're going to see the patient what is the type of respiratory failure, and you're going to intubate the patient. If in case of CO2 retention, all we go for like NIV only, non-invasive ventilation. The patient is cooperative and all. We're going for NIV, and we're going to take down the CO2 retention CO2 by keeping the respirator high. So this impending respiratory sign failures are there means you're going to intubate the patient. So this all like if you're having like you're going to do a surgeries that requires GA means you're going to intubate the patient. That GA surgeries you're going to intubate the patient. This all are the special like indication of the indication for intubations. So coming to the options, non-invasive ventilation means going to put the NIV to the for this patient? No, never. Patient is already having like less GCS, already so many parameters are dearranged. He is in acidosis. He already having like air hunger is there. You're going to definitely going to not going to wait. You're going to take a tube, take a laryngoscope, take a airway devices, and you're going to intubate the patient. So coming to the airway management, so there is a sequel. There is a sequence. There is a sequence here. First, so coming to the airway management here, how are we going to manage airway? So there are two different management. One is emergency Emergency management. So patient came to you. Okay, just I'll give you just a scenario. Patient came to you. You're working in a like EMC department, emergency response team, emergency. You're working in an emergency response team in a emergency department. Patient came to you with a like traumatic brain injury. Patient is unconscious. You got the patient. What are you going to do? First, you're going to like basic level, normal emergency management, basic level of treatment will be there. After that, advanced will be there. So now you're working. I told no emergency department. You're working means like there will be a like emergency management or basic management. And next, like definitive management or advanced. In emergency, what we'll do, we're going to first stabilize the patient, stabilize the vitals, stabilize the SpO2, stabilize the SO2. All this you're going to stabilize. After that, you're having the time. You stabilize the patient. Patient vitals are fine. Means you'll be going for definitive management, and you're going for advanced management. In airway, if you see basic airway management, what are the basic airway devices are there? First, you're going to try with OPA. What is OPA? Oropharyngeal airway. These are the devices. Okay, these are the device will mainly prevent the tongue fallback, and it will prevent the aspiration. It will prevent the tongue fallback and tongue like obstructing the trachea. So it will connect the mouth to trachea, like from air from mouth to trachea. It will connect. It going to bridge the mouth upper like atmosphere to the trachea. So the trachea will be getting some O2 through atmosphere. There are so many the oral airway devices are there, like namely Berman's airway, Guddle's airway. I think everyone saw this Guddle's airway in your like day-to-day routine practice if you're working in hospitals and all means. ORCFN airway. It's all like different kinds of oral airways and nasopharyngeal airway NPA, nasopharyngeal airway. One like a very flexible rubber tube will be there. Rubber tube will be there. It will be placed in nose. It will connect the nasal cavity to the trachea. If oral airway is contraindicated, means you're going to go for like NPA. So this is a basic airway. Coming to the definitive management of airway, definitive, what are you going to definitive or like stable after stabilizing all these things? What are you going to do? You're going to do oral intubation. You're going to take the you're going to take the endotracheal tube and you're going to place inside the trachea. Oral intubation, orotracheal intubation. In the short form, what we call as endotracheal tube. And then if oral airway is obstructed, you're having a long ranula inside the mouth, tongue is like bigger tongue, you're having like CA of mucosa, CA like upper mucosa and all means you're not going to do like oral intubation. You'll be going for nasal intubation. Nasal intubation. Okay, one flexo metallic tube will be there that you're going to place inside the trachea. So next, coming to the next point, you're going to if your upper airway is completely distorted, upper airway is completely like damaged, you'll be having CA larynx, CA pharynx, and if you're having like long like a bigger adenoids, you're having like CM buccal mucosa, CA lateral border of tongue means you're going to tracheostomize the patient. Tracheostomy, a small tube like small tracheostomy tube, which like some tubes are covered, some tubes are non-covered tube you're going to place inside the trachea. By in the third or fourth tracheal ring, you're going to make an incision, keep it open, That's why we call as ostemo, like opening inside the trachea and put a tube inside the trachea. That is what it is, whatever tracheostomy. So it will be an emergency, definitive, life-saving procedure. So these all are your basic and advanced airway management. In that, like if you take out the basic and advanced airway, one more thing new added, like updated one is there, updated airway management. Hmm. What I told, like basic and definitive, emergency and definitive airway management is there. In that, like we are having some hybrid management. Hybrid means in between, not advanced, not a basic. In that, you will be having LMA. What is LMA? Laryngeal mask airway. LMA. Also called as supraglottic airway. So LMA comes under hybrid airway management, not basic, not to the advanced. Okay, laryngeal mask airway means it is placed above the trachea, just above the glottis. So you're going to, like, if in case of difficult intubation, you cannot able to intubate the patient, you cannot able to ventilate the patient, means you're going to put the LMA inside the trachea, inside the above the glottis, and you're going to ventilate the patient. So these are the like special device, like flexible device. We'll be like blindly we're going to insert inside the trachea, and we're going to ventilate the patient with the ambu, or we'll connect to the ventilator, or we'll connect to the base, and we'll try to ventilate the patient. And one more thing is there, one more like blind insertion device, in that only that LMA will come. There are so many different types of LMA are available. Pro seal LMA, Pro seal LMA, intubating LMA, and IGEL LMA. So different, like based on like generations, there are different types of LMAs are available. And next, combi tube, combi tube will be having like two tube combi. The name itself it shows that it will be having like two tube. Sorry. Mhm. I see two tubes will be there. One will be going like longer one. One will be uh, this is the combi tube. Okay. You'll be having like two tubes will be there. Tube number one, tube number two. Like blindly, we're going to insert inside the trachea. We'll inflate the both cuff, and we're going to try to ventilate the patient. So in from here, you will be having like two tubes will be there. PCU means two tubes will be there. First, I'll try to ventilate with this one, and I'll try to see the chest is getting raised or not. If chest is getting raised or not, rising means the tube number one universal adapter will be there. No, that will try to ventilate. If that is going to like rise the chest means it is there in trachea. The first tube number one is in trachea. If it is not there in trachea, what will happen? See, this is a beautiful concept here. In case of, we'll see now, we'll intubate the patient, we'll try to put a bamboo, we'll try to connect the ventilator and all, we'll see there is no chest rise in there. So, during intubation, the resident or like some like research nurse is place the tube inside the stomach, not place it inside the trachea. So that's why there is no chest rise wall and all. There is no air entry there, equal air entry there. That's indicative of like displacement of the tube into the stomach. So to avoid that one, we are having combi tube. Okay, we have put the same tube like blindly without any like scope and all. We don't know patient is like tube is going in trachea or what. The two tubes are there. One tube approximately it will go to like, about 2 centimeters above the carina, and one more tube will go to the it will be about a little bit above the place. It means if the tube is like placed inside, we don't know where is it. First, we'll try to put the tube inside that again. We'll try to ventilate. Rise it there means tube number one is there in lungs, is there in trachea. That's why chest rise and fall is there. If if chest rise is there and it's not there means the tube is there in stomach. So I'll try to change that ambu bag and I'll connect to tube number two and try to enter. If that time if a tube is like chest is getting the chest size is there means the indicator of tube number two is in lungs. So only this tube I'm going to ventilate. This tube I'll be keep closed. Okay. This one is combi tube and one more is the King's tube. So this all are the your hybrid airway management devices. Okay. Coming to the question. So we choose the answer called as endotracheal intubation. We're going to intubate the patient. If you see the patient, okay, just imagine if you're working in a like ICU and all, you see the patient is crashing, patient is agitated, patient is having like AVG parameters full dearranged. It means if GCS is less than 8 and almost, finally you will not wait for anything. You will take the tube and you will intubate the patient and you will ventilate the patient. You will save the patient. That's all. Okay, if you going to like briefly to the intubation process, what are the main like aspect? What and all you needed for intubation? So I'll give a. There are mainly like two types of intubation is there. First one is your like routine normal intubation, routine intubation, and second one is will be your rapid sequence intubation. Both the same, almost like similarities are there, but in rapid in case of your rapid sequence intubation, what we call as RSI, rapid sequence intubation, we were giving the muscle relaxant which are short acting, and we are not going to take the time like after like an apnea period, after like a patient is completely sedated, till that patient is getting intubated. That time like less than 20 to 60 seconds means less than 1 minute. We're going to intubate the patient. We're going to place the tube after the sedating the patient. That we call as rapid sequence intubation. And normal or routine like elective intubations will be we'll be giving the we procedure wise we're going to ventilate the pre-oxygenate the patient. We're going to like give the 2 minutes of hyperoxygenation state. We're going to do the long acting time taking muscle relaxant, and we're going to induce the sedation. We're going to paralyze the patient. Then we're going to place the tube and we're going to answer the tube. So coming to the routine intubation, what are the like major things you would require for the intubation is salt. We need salt for if you think if you're preparing something, if you're preparing rice, sambar means you need it. Salt is like essential for intubation also. Salt is very necessary. What is salt? S for suction. Before intubation, you have to clear the airway, you have to clear the suction, you have to clear the all secretion in upper airway. If you're not clearing the secretion, means what will happen? Soon you're going to give the position and all, if snipping position you have to give, and you have to make the bed flat and all, you're going to relax it, everything you've done. But you've not done a suction. See, if you put the tube, you're not going to visualize the trachea because the all like upper airway is filled with secretion. All your upper airway or your saliva, everything will be there. That will be completely obstructing the upper airway. We cannot able to visualize the trachea. Then how are we going to intubate the patient? So suction is a best thing you have to do before intubating the patient. So keep in mind that you have to keep ready suction devices, a Yonker device, suction catheter, and wall mounted suction tubings. All three should be made ready before intubating the patient. So then A for airway devices. What are the airway devices? I told no NPA, nasopharyngeal airway, OPA, and Guddles airway device you have to keep, and you have to keep the AEC. What is AEC? Airway exchange catheters. All else airway guidance catheter, airway exchange catheters. We call as these are like guiding wires. These are like guiding tubes that are going to guide you during intubation. That are mainly your bougie and stillet. All of you like will be knowing now this one bougie, like a blue color tube or white color tube will be there, like will be not having any holes and all. Like long bougie will be there, will be having like anatomical curve will be there. And that will be first like, in case of difficult intubation and all, first we'll take a laryngoscope and we'll put inside the mouth and we're putting first we're going to introduce the airway exchange catheter. First, we're going to put the buoy and we'll confirm the position. Then we're going to on top of that buoy, we're going to put a endotracheal tube, and then we're going to easily intubate the patient. We're going to take out the buoy out. If in case of like too much like a difficult airway is there, means we're going to take the stillet and we're going to put the stillet inside the trachea, and we're going to put the like already like pre-inserted stillet will be there inside the trachea, inside the endotracheal tube, and we're going to introduce inside the trachea. We need airway devices. We need AEC, airway exchange catheters, and L means like L means laryngoscope. What we need? Laryngoscope. That may be VLS, video laryngoscope or normal laryngoscope. NLS, VLS or NLS, normal laryngoscope. We needed a laryngoscope for proper visualization of larynx and trachea. Okay. Next, coming to the T. What is T? Salt. Salt, field salt. All of you know field salt, no? As you've been clear. This time we won the trophy because of Kohli and salt. Like Moro, it's in teamwork only. Field salt. T for tubes. What are the tubes you're going to keep ready? Endotracheal tube. Okay, what are the different? How will you choose the endotracheal tube? There is a formula relating to age, relating to height, relating to according to body weight and all. It is there, but like usually in day-to-day practice, we'll be using for adult male 7.5 to 8.5 like tubes we are going to use. For females, 6.5 to 7.5 of tubes will be used. ED tube, endotracheal tube. For tracheostomy and all, TT tube 7.5 to 8.5 for adults, same 6.5 to 8.5 for females. Tracheostomy tubes. These tubes are kept ready during before intubation. Salt tubings. This all is ready. Okay, this all are ready. Then you want to it's all like pre-requisition or the instrument needed or the device needed for the rapid sequence intubation or like normal elective intubation means this also ready. All things are ready means further you're going to next what you're going to do. This all are comes under like prepare. You prepared. Then you're going to what you're going to do? We're going to pre-oxygenate the patient. After no. Actually, we have to give the position, a normal position. What the position we're going to after preparation all instrument. What we're going to do? We're going to give the position for the patient. Which position will give? Sniffing position or a ramp position. Based on like C-spine status, we will be giving the position. We given the position. We pre-oxygenate the patient. We induce the patient. Means we given the sedations. Then we given the sedation. After that, we done a paralysis. We given a muscle relaxant. Now patient muscles is relaxed. Patient is sedated. Then you're going to place the tube. What is a proper placement of the tube? Like probable question for NORCET and all. If you see like proper placement of the tube. Regarding placement of the tube and confirm till now like there will be there like all the questions they're asking the confirmatory after like post intubation. How will you confirm the tube in proper position? Like this is will be like highlighted. what to say, like there is no question paper like it's not having a post intubation confirmation of tube inside the trachea. It's like I saw like I done I given so many exams. All exams they are asking like confirmatory findings. How will you confirm the tube is in trachea? So if you like see according to situations and all means how like, first of all like they are having like I'll tell you it goes on priority. First you are having option called as chest X-ray. Next, how will you confirm on chest X-ray? How will you confirm means okay there will be a, if you like see the tube like ED tube, it will be like this more or like similar on universal adapter will be there. Here on universal adapter will be there, and here what is your cuff will be there, and cuff will attach it with the one pilot balloon, one way wall, and then here on radio opaque line will be there, and here two black lines will be there, and here your length markings will be there. So this is your like a endotracheal tube. This is a bevel, and one more here like, Murphy's eye will be there. Murphy's eye. Murphy's eye like this acts as a window. It acts as a window. If in case of like bubble, like main opening, a tip of a tube is blocked, it means the patient is going to ventilate it by the Murphy's eye, like window. It's an extra channel which is given to endotracheal tube in case of a normal tube or like अब main रास्ता खत्म हो गई तो like और एक रास्ता है that will be a, even Murphy's eye that is going to act as channelize for ventilating the patient. And nowadays we are having the cuff. Before and all, we used to have like a high pressure, low volume cuffs will be there. What will cause if high pressure is there means what will cause the tube is in trachea. Trachea is having a normal like mucosa will be there, like a soft mucosa will be there. That epithelium will be there, epithelial mucosa will be there. So that will be if you're going to give a more pressure means more pressure, high pressure means that is going to like cause a tracheal ischemia, tracheal damage, tracheal necrosis will be there. So that's why we are nowadays we are using less pressure, high volume. You want to inject the more air, but less pressure will be there though. So there will be a tube securing will be there, and there will be a less chance of necrosis will be there, tracheal ischemia will be there. So we're going to choose the mm, less pressure, high volume tubes will be used nowadays. So this will be a what I told like two black margins. These are vocal cord marking indicators. And this one is your length indicator. Or how will you place like this tube placement? Placement I told on X-ray, you will be seeing the vocal cord marking. This must be 2 centimeter above the carina. What I told like on X confirmation. Okay, tube placement. Tube placement. How will you confirm? How will you confirm that tube is in proper place? One is I told what I told. Just X-ray. On chest X-ray, what you will see, the vocal cord marking will be like 2 centimeter below the vocal cord. So we're coming to the tube placement. uh, First one, chest X-ray. What I told, like it will be like 2 centimeter below the vocal cord and 5 centimeter above the carina. See, the tube is placed after you intubate the patient. Given like after successful intubation, you started to ventilate the patient. Patient ventilating okay. But you take a X-ray, it will shows like on like two markers will be there, like two black markers like on a ET tube will be there. If that is like 2 centimeter below the vocal cord and 5 centimeter above the carina, that will be your proper placement of tube. See, think, imagine if that is like below the carina, below some 7 centimeter of the carina. If that black marking is like at the carina, what will happen? The carina is very having high parasympathetic nerve supply. If you try to trigger the carina means the patient go for vagal bradycardia. Vagal nerve stimulation with the patient going for vagal bradycardia. So to prevent that one, we'll be placing the tube 5 centimeter above the carina. So there will be a no vagal stimulation, there will be no vagal bradycardia. And if it is like above or like 1 centimeter or 1.5 centimeter below the vocal cord means what will happen? We'll put the what I told like we are putting the high volume means that length of area covered by cuff is more nowadays. So what will happen if you try to expand that cuff in like near to that vocal cord and local cord palsy will be there, like permanent vocal cord palsy will be there, patient will be not able to produce a sound and all. So the proper placement will be like 2 centimeter below the vocal cord and 5 centimeter above the carina. And if we come into next one, EtCO2. What is EtCO2? And tidal carbon dioxide. We're going to measure the EtCO2. Normal it will be around 35 to 45 mm Hg. Normal EtCO2 and tidal carbon dioxide value. How will you measure that one? We'll connect the universal adapter of endotracheal tube to the EtCO2 device and that will be connected to the ventilator. The ventilator monitor will show the EtCO2 value. If it is like less than 35, it is more than 90 or 45, it indicates of tube is not placed inside the trachea. It will show like on ventilator, it will show the graphings like this: inspiratory, expiratory, inspiratory, expiratory. This is normal capnography. Capno. What is capno? Capno means carbon dioxide. Graphy means capnography. What it is? Capnography. Cap means carbon dioxide. Graphy means graph. CO2 graph. That is normal graph. Okay, if it is like abnormal value less than like 35 means it indicative of a tube is placed inside the stomach and all. And next, what you will do? You will auscult. You will take the stethoscope after placement of immediately after placing the tube. What you will do? You will do auscultation. How will you auscult the patient? He'll put a stethoscope. He'll put a stethoscope. He'll put into the ear plug, and then the diaphragm was kept. It will be placed first anteriorly, bilateral anterior air entry and bilateral basal air entry. First, you're going to keep the stethoscope inside the like over the chest, and you're going to feel for air entry, conductive sounds. Sounds are there means like conductive sound means yeah, bronchovesicular, tracheobronchial sounds are there means that indicative of which air entry is that the tube is properly placed. Anterior entry is that both bilaterally like right and left side. Then that if you cannot able to see the like conductive sound or airway sounds in left side, only you can able to see the lung sounds in left side means the tube is like too much advanced. Tube is gone into the left bronchus. It is not in right bronchus. So only left lung is going to ventilate. If that situation is there, means just imagine the tube is in left bronchus. What will happen? The only one lung is getting ventilated. Another lung is getting collapsed. There is no air until there is no air is going in and out. Means if you see like balloon is going, if you're going to inflate the balloon with the like pump means it will open. So same thing, like if you're not going to push the air inside the lungs means the lungs is going to collapse. The alveoli is getting to collapse. Alveoli is collapsed, atelectasis. There is no ventilation perfusion. There will be a mismatch of ventilation perfusion. So what you're going to do? You're going to do auscultation. Okay, you're going to take a step and auscult anteriorly and and basal or or lower lungs field you're going to auscult. And next, what you're going to do? Auscultation of anteriorly and posteriorly, also like lateral. You can auscult the patient. Air entry. What you're going to see mainly air entry. If air entry is properly there, both in right and left lung means that indicate your proper placement of the tube. And next, what are you going to do? And you're going to observe, inspect. What you're going to observe, inspect for chest wall rise. So based on priority, if they will ask you like what is immediately after placing tube, what you going to confirm, what you going to confirm, how you going to confirm the proper tube placement means you're going to do a auscultation. They're going to ask like what is a like proper appropriate action. If there is no like immediate and all means you're going to choose the chest X-ray. If they ask it like according to the like ASA Anesthesia Airway Society American Society of Airway means it is an ETCO2. So that the answer is very debatable. It depends on the situation, depends on the key points. So answer will be varying. Like in general, they ask it means you go for like chest X-ray. So this is all about like intubation criteria, like step of intubation, tube placement, about like little bit about the tube labels, how the tube will be, and all. So going to like next question. Coming to the next question. So you're having the patient. Rang the patient, a 32-year-old male came to emergency department. Okay, we were now this time we were having the young person came to emergency department with unresponsiveness. Patient is not having any consciousness. Patient is comatose. Like patient is not obeying and all. And presenting his presenting vitals are like 95 by 39 mmHg of BP and SpO2 of 65 percentage. And here are your examination findings. So what is Malampatti grade of 3. Mainly abnormal findings. This one, export is coming down, and your BP is going to like BP till now it is okay only, but diastolic is lower side. Diastolic hypotension is there. What are the examination findings are there? Malampatti grade 3, stiffness on ventilation, and a and a distorted airway is there. So further, like what you as being a nursing officer, what you going to proceed with? So think, okay, just think, relax and think. Read the question carefully. First of all, you have to read the question like one or two times. One time, first time you didn't understood, like go for second time. Till you understand the like question, you have to go through the question clearly and understand the like pick up the key points. So now we are having engaged old patient, like normal age patient, came to the emergency department. Patient is unresponsive. So, what last question I asked, like I given you like briefly, I told you like GCS, GCS, and in this patient, like this person like is having unresponsiveness. GCS is done in like in case of like emergency. But if patient is came to you in ED and all means you have to go for another scale called as AVPU score. This is a new scoring system used in emergency, like critical illness or critical case and all. We're going to use AVPU scoring. What is AVPU stand for? A for alertness, B for verbal response, P for pain response, U for unresponsiveness. So now patient is unresponsive means U stage. Patient is U stage. And patient is having like a BP is also crashing, diastolic hypotension, and SpO2 is like less 65%. Means patient is in hypoxic state. So Malampatti score, like it is like a score used for mouth opening. 1 and 2 score indicate your patient is having like a you can able to see the vulva, soft palate, and like kind of you can able to see means that will be like a normal grading and all. If you're not going to see vulva soft palatal means go for like three grade three and grade four. It means mouth opening is not the difficult mouth opening. It means that there will be a grade three and grade four. In case of like before intubation anesthetics or like nurse practicing in anesthesia and all anesthetic nurse means they will going to examine the patient for malampati score. He's trying to put the mouth and open the mouth and all. If he's cannot able to open the mouth in two finger and he cannot able to see the vulva soft palate means that will be grade 3 and grade 4. Grade 1 and grade 2 like indicative of you can able to intubate the patient. There is no like that much difficult airway and all. Grade 3 and grade 4 means it indicative of difficult airway. You're going to use a special device for intubation and all. And stiffness means if mouth is not opening, you put a ambu and you try to ventilate the patient. But you feel too much resistance, too much compliance to push the ambu bag. So, okay, that is also like abnormal finding only. Coming to the distorted airway means airway is not proper. So upper airway is not proper, like lower airway or upper airway is not properly, like anatomically abnormality is there, distorted airway is there. So as being a nurse, or as being a like patient or like a nurse practitioner, what are you going to proceed with? So this kind of patient crashing patient is there. Now your options are here follows O2 therapy. You're going to start O2 with a NABM mask, or you're going to do supraglottic. You're going to put the hybrid. I told no LMA laryngeal mask airway. Same thing. Supraglottic device. All this comes under category of blind airway insertion devices. And the third option is BiPAP or NIV. BiPAP, bi-level positive airway pressure ventilation. BiPAP. BiPAP. Bi-level means inspiratory. Two. Two. Bi means two. Always two. Split and okay. You have to like what are the topics are there? What the concept is there? You have to like, divide. You have to dissect the word and read. Bi-level. Bi-level means two level. IPAP and EPAP. Inspiratory positive airway pressure ventilation. Expiratory positive airway pressure ventilation BiPAP. And last option is E-FONA. What is E-FONA? E-FONA. E stand for emergency. Emergency. F for front of neck access. Means like in simple form, cricothyroidotomy. Cricothyroidotomy. Means like this will be like a needle, or we say needle or scalpel. See, patient is we are having the patient like you can see no patient is unresponsive, BP is crashing, SpO2 is coming down, and this like Mallampati is grade 3. Can you intubate the patient? Just think for a while. Just think all of you. Just take a time and think here. BP is crashing, SpO2 is down. Can you able to intubate the patient? Yes. Yes. No. See, we're not going to intubate the patient. Why? Because difficult intubation, Mallampati grade 3, patient mouth opening is not there, cannot able to put the L scope. Laryngoscope is not cannot able to place, cannot able to see vulva. You're not going to see the triangle of intubation. All means it is very difficult to put the tube inside the trachea. And if you like put an ambu and connect a bag and mask ventilation means there is stiffness, there is too much of compliance, means upper airway is distorted, having some abnormality, having some like tumor in sitting inside that inside your upper airway and is it's blocking fully your upper airway. So that time, what are you going to do? What are you going to do? Think and tell me. So we cannot able to intubate. There is a condition. Okay, there is a situation for you now. You're facing a situation called as what? Now presently you're facing a situation can't intubate, can't oxygenate. CACO. What it is? Can't intubate, cannot able to intubate, and can't oxygenate. Cannot able to intubate means cannot able to put a BM, ambu, cannot able to bathe the patient means you cannot able to you're not ventilating or not oxygenating the patient. That situation is came in front of you because mouth opening is not there, distorted upper airway, and his patient SpO2 is coming down, his patient is unresponsive. So all these are like indicative of patient is not ventilating, not ventilating. There is no inspiration, there is no expiration. So this situation, what I am going to do, I am going to take a large bore needle. What I am going to take? Take large bore needle, like a 14 or 16 gauge needle. I am going to take, and I'm going to localize the cricothyroid membrane I'm going to localize, and I'm going to give a horizontal cut. See, this one is your, like thyroid bone and all. This one is thyroid bone. This one is your thyroid membrane. Means here exactly, cricothyroid membrane is there. Here I'm going to horizontally cut the cricothyroid membrane cartilage. Membrane I'm going to cut, and I'm going to put the, like I'm going to keep the still. I'm going to take out the slit, and I'm going to keep the plastic metal, PVC metal inside the trachea. So that one you can able to, like you can able to channelize, you can able to ventilate the patient through needle, large bore needle. Or else I can go for, nowadays we are having a front needle access kits are there available, like needle cricotomy kits are available. You can use that one. Or else what I'm going to do, I'm going to take the scalpel like 11 blade, 11 number blade. I'm going to cut horizontally. Okay, into the cricothyroid membrane. I'm going to put the plastic or PVC material tube inside the cricothyroid membrane. So that will I'll connect to small like ambu bag, and I'll try to ventilate the patient. So this situation is called as can't intubate and can't vaccinate. You cannot able to intubate the patient, you cannot able to ventilate the patient. That time you're going to go for front needle access cricothyroidotomy. So coming to the question. So that I what I told, no, patient is unresponsive, BP is dropping, SpO2 is dropping, Mallampati grade 3, sickness and ventilation, distorted airway. Directly go for directly go for what? Your E4 Okay, emergency front needle access. So next question. There is an algorithm. Okay, there is an algorithm called as lemon criteria, Broad's criteria, and short criteria and all. You just try to read and come next topic. Next class we're going to deal with that. So coming to third question, Airway series third question. Now this time there is no scenario, there is no patient and all. Just you need to tell me the rapid sequence intubation sequelae, RSI. I don't know last topic where we like studied intubation. See this one. Yeah, here. I told you initially only I told you a rapid sequence intubation sequelae. So your options are here. First, you're going to pre-oxygenate the patient. Then you're going to prepare. Then you're going to pre-treatment. Your options are like pre-treatment and paralyze and placement of the tube. Post-intubation management. So this is your first option. Next option is your prepare position, pre-oxygenate, pre-treatment, induce, paralyze, and place the tube, and post-placement of the tube management. Option C is your position the patient, paralyze the patient, induce the patient, place the tube, pre-oxygenate, post-intubation management. This all are like you can able to see now. These options are not right. First you want to view position. Yes, you can give. Paralyze the patient. Then induce. No, first you have to induce, then you have to paralyze. place the tube, then after that you pre-oxygenate. No, never. Never will do. So coming to the right answer is your B. B for Bombay. Okay, first option, proper option, right option is your B. Okay. This, okay, I'll tell you. Prepare. What you have to prepare for? What I told. How to prepare for equipment. What are the like things needed for intubation? Prepare. Keep things already at the bedside and make a tray, intubation tray. Keep a intubation tray ready with all the things, salt, fill salt. I told no, fill salt. Test for suctioning, Young suction device, normal suction, plain suction, thumb control suction device, valve mounted suction catheter tip. A for airway, you have to keep the airways all oral airway, nasal pharyngeal airway, and you have to keep the air, the oroendotracheal tube, tracheostomy tube, all tubes ready. Then you're going to keep the laryngoscope, video laryngoscope or normal laryngoscope, light laryngoscope. And you have to keep the tubes ready, all tubes, endotracheal tube or tracheostomy tube with proper size according to like patient body weight and all. You can keep the size of 7.5, 6.5, 8 and all you can keep. Then after preparing, you prepared and you have to keep prepare all the anesthetic and paralyzing drugs, paralyzing agents. Like for sedation, you're going to use mainly midazolam and fentanyl. You're going to use. So I'll take a I'll take a new slide. I'm going to explain you clearly. You can take a notes of it because it'll be like I think like in 2022 like this question is asked like sequence of intubation is been like asked in 23 21 NORCET. So first what do you want to do? You're going to prepare. What are you going to prepare for? Drugs and salt. What are the drugs you will use? Sedation. You have to sedate the patient because the patient is awake means we cannot able to intubate the patient. There will be too much resistance. There will be a too much like stiffness. Will be muscle spasms will be there. So you have to give the sedation. What are like mainly sedation you'll use? Fentanyl, opioid kind, opioid analgesics, opioid as sedatives, midazolam, propofol, and you have to use the MR, muscle relaxant. Why you're going to use the muscle relaxant? See, if you open the like trachea, if you open the laryngoscope and all, if try to put the laryngoscope inside and try to put the tube in, that time you'll feel some a tracheal spasm or like pharyngeal spasm will be there. Tube will not go advance further down because some stimulus you given, some tube is going inside means there will be a rapid response from from pharyngeal muscles will be there. Rapidly it will contract, rapidly there will be a spasm will be there. So you have to relax the patient. Then the muscle will be relaxed. There won't be like resistance will not be there. So you have to properly relax the patient by giving paralyzing agent. There are like short acting and long acting are there. Normally we'll use track, atracurium, vecuronium, rocuronium, and succinylcholine. Succinylcholine. It's all like muscle relaxant. We mainly like in rapid sequence intubation, we're going to use rocuronium and succinylcholine. Succi and roxa will use. Okay. Now this atracurium and vecurium is using normal like elective intubation will be used. So we are discussing a rapid sequence intubation. So in that situation, we're going to use the rocuronium and succinylcholine. You prepare the patient, then you have to position the patient. I told you no, we have to give the position, proper position that will open the airway. Normally, we'll do some maneuvers called as jaw thrust maneuver. We'll put two fingers inside the TM joint, temporomandibular joint. We're going to lift the jaw, mandible. We're going to lift the mandible. Then our upper airway will open. So that we can do, and we can do head tilt and chin lift. According to like C spine stability. If C spine fracture resistance, we're going to go for jaw thrust. If C spine is okay, means we're going to go for like a head tilt and chin lift maneuver. We can do when we can open the airway. Or else we can go to put the like airway device. Our head airway, we can open the airway. So what position we're going to give? We're going to give sniffing position or ramp position, or we can able to do like jaw thrust maneuver, or you're going to do chin lift head tilt maneuver. Okay, then you given the position, you kept all like sedatives, all drugs, all tubes, all suction tubes, everything you prepared, and you given the position for the patient, sniffing position you given. Next, what you are going to do? You are going to pre-treat the patient. What you are going to pre-treat the patient? You are going to give the like drugs, IM atropine or glycopyrrolate injection, IM. Why you are going to pre-treatment the patient? Pre-treatment is the patient. Why you are giving atropine? Why you are giving glycopyrrolate and all? See, during intervention, what I told you, have to do suction. Why you have to do suction? Patient is unconscious. We sedate the patient. All your like saliva, all your upper airway excretion are going to pool inside your trachea and all. So to reduce the respiratory secretion, nasopharyngeal secretion, we have to give the anti-muscarinic and anticholinergic. We have to give that atropine and glycopyrrolate. Both are the anti-muscarinics. Okay, that will reduce your upper respiratory secretions. So there will not be pooling, there will not be aspiration, there will not be a lodging dislocation of or nasal secretion into the trachea and all. So we're going to pre-treatmentize the patient with atropine and glycopyrrolate, and we're going to induce the patient, induce the sedation. What I told, we already prepared with the drugs, sedatives, fentanyl. Normally, fentanyl will give, or if patient is not sedating, we'll give medas. Till the patient is not sedating, we'll give the propofol. 10 mg of propofol will give, 1 mg of medas will give, some 100 mg of fentanyl will give. After that, we induce the patient. We induce the adequate sedation. We induce the adequate sedation for this patient. Next, next, what you're going to do? Basavana, 1 minute. Sorry for the distraction. So what I told, like we induced the patient with sedation, fentanyl or propofol we given. We after that if we given sedation, between sedated. Now we want the patient to be paralyzed. We're going to paralyze the patient means we're going to relax the muscle. MR muscle relaxant we will give. What the muscle relaxant specially will give? This is a, like rapid sequence intubation (RSI). Rapid intubation will prefer succinal choline or rocuronium. What I told, we will give the rocuronium. We given the rocuronium and we relax the patient. Now muscle relaxant is there. Now what we'll do? We everything is ready, prepared. The drugs position we given. Oh, sorry, we missed some. After positioning, see after positioning, we have to give the patient with 100% FiO2. We have to oxygenate the patient with 100% FiO2. We'll connect the patient to O2 source. We'll take him on Bain circuit or ambu bag, and with 15 liters flow in a flow meter, we'll ventilate the patient for a 2 minute. We'll ventilate the patient with 100% FiO2 for a 2 minute. We'll hyperoxygenate the patient to prevent the hypoxic injury during placement of the tube. So first prepared, given position, and after that we pre-oxygenate the patient 100% FiO2. We pre-treated the patient with IM atropine and glycopyrrolate. After that, we induce the patient with sedation. Okay, fentanyl and medas and propofol we given, and we paralyze the patient. We given muscle relaxant called as rocuronium and succinylcholine choline we given. Now everything is ready. Patient is ready for placing the tube. We place the endotracheal tube inside the trachea. Okay, we'll place a tube with the using laryngoscope guidance or and the guidance of Boozy or Slate airway extender device. We use that guidance. We place the proper tube inside the trachea, like 2 centimeter below the vocal cord and 5 centimeter above the carina. We place it 5 centimeter above the carina. We place the tube. So next, what are you going to do is post tube placement management. So we'll confirm the tube. I will confirm. We'll take the X-ray. Uh, Sorry for the inconvenience.